Hi all, welcome to RAAONLINE. Today we are going to deal with one important investigation in the preoperative period, the knowledge of which is very important for all anesthesiologists. That is nothing but echocardiogram. How you interpret the echo report. There are many indications for perioperative echocardiogram. You have class 1 indication, class 2A, B and class 3. But the classical class 1 indication for perioperative echocardiogram is acute hemodynamic instability of unknown etiologies. As an anesthesiologist, you will face this situation in the perioperative period at any time. At that time, the knowledge of echocardiogram will come in handy to rescue the patient. This is the echocardiogram of my parent institution. But what we do, we go and look at the last line ejection fraction. If ejection fraction is normal, we will go and anesthetize the case. But there are many other parameters to be taken care of in the echocardiogram report. Here, you have the dimensions of the left ventricle, volume parameters, you have the fractional shortening and iota-LA ratio, you have the velocity across all the 4 valves and the anatomy of all the 4 valves, your congenital heart disease, whether your intraatrial septum and interventricular septum is normal, regional wall motion abnormalities. Apart from that, you have to look at the pericardium and great vessels. So many things are there in the echocardiogram, but we look at one parameter and anesthetize the case. Also, it is very important to compare the patient value with the normal value which is given in the echo report. Before going to analyze the echo report, we should have the views of various transthoracic echocardiogram. This is called FATE, which is focus assess transthoracic echocardiogram. Here you have 4 primary views. One is the subcostal, followed by apical, then third one is the parasternal, and the fourth one is the pleural scanning. In addition, one more view is there, which is the suprasternal view to assess the great vessel. Here you can see the subcostal view, second is apical, third is the parasternal, and fourth is the pleural. And in addition, you have the suprasternal view to assess the great vessels. Now coming to subcostal. Here you place the probe in the subcostal part and you cross the liver to examine the 4 chambers of the heart. Here you have the right ventricle, right atrium, left atrium and the left ventricle. Here you can see this is the right ventricle, the tricuspid valve, right atrium, and here you have the left ventricle and the left atrium. In this view, you can even look at the intraatrial septum and the interventricular septum along with the 4 chambers of the heart. Next comes the subcostal view for the IVC diameter. Assessing the volume preload of the heart, this view is very important. All you do is measure the IVC diameter and the collapsibility index of the inferior vena cava. Now coming to the apical view, you place the probe in the apical part and you cut the heart at 3 different angles. You move the probe counterclockwise to get 3 different views. In the first view, you get a nice 4 chamber view. Here you can see the left ventricle, left atrium, right ventricle and the right atrium along with both the valves, mitral and the tricuspid valve. Your pictorial representation is here. Then as you rotate the probe counterclockwise at 90 degrees, you get the 2 chamber view. Here you have the left ventricle, mitral valve and the left atrium, and this is the anterior wall. And this will be the inferior wall. Then as you rotate the probe another 90 degrees, you get what is the 3-chamber view. Here you have the left atrium, left ventricle, and here you have the aortic valve and the aorta, and you can have the right ventricle here. So that is the 3-chamber view. Now coming to the parasternal view, where you place the probe directly over the heart and the probe light will be towards the right shoulder. Now you place the probe over the heart. Here cardiac structure is being seen. Here you have the left ventricle. This is the left atrium and you have the mitral valve in between. This is the right ventricular outflow tract. This is the ascending aorta and this is the descending aorta, and here is the pleural space. This is the parasternal long axis view. Right ventricular outflow tract, left ventricular cavity, aortic valve, mitral valve and the LA. This is the descending aorta and this is the ascending aorta. There is a small pleural collection. This view is very important in measurement mode. Here you can measure the dimension of the right ventricle, you can measure the septum, you can measure the posterior wall dimension of the left ventricle. And if you place a cursor across the aorta, you can measure the aortic diameter and the LA diameter. This aortic LA diameter is very important in assessment of the left ventricle. Then comes the parasternal short axis view. Here you can see the LV at the level of mitral valve, at the level of papillary muscle and the contraction. This is very important in assessing the walls of the left ventricle, and also you can look at the aortic valve. All the 3 cusps of the aortic valve can be seen with the inflow to the right ventricle as well as outflow. You can measure the PA diameter as well as the right and left branch pulmonary arteries. Next comes the pleural view, where you place the probe on the sidewards and you have to cross the spleen and lung to look for any pleural collection. You cross the spleen and the lung and you can see for some volume management. The last view is the suprasternal view. You place on the suprasternum. This is the ascending aorta, this is the descending aorta, and this one is the brachiocephalic, and you followed by left common carotid and the left subclavian artery. Now coming to the various parameters in the echo report. The first and foremost which we see is the ejection fraction. What is this ejection fraction? It is nothing but end diastolic volume minus end systolic volume, which is the stroke volume, divided by end diastolic volume. What is end diastole? The end diastole is nothing but where your mitral valve is open, and end systole is when your mitral valve is closed. You measure the volume by Simpson method in end diastole and end systole and calculate the ejection fraction. The normal ejection fraction is around 55 to 75%. Instead of ejection, instead of measuring the volume, if you measure the dimensions of the left ventricle, here you take the parasternal long axis and you measure the diameter of the left ventricle in end diastole. Here you can see the mitral valve nicely open, and here you can see the mitral valve nicely closed. The diameter at end diastole is 4.5 and the diameter at end systole is 3.1 centimeter. By applying the same formula which you did for ejection fraction, if you apply it, you get a fractional shortening of 31%. The normal value is between 30 to 45%. Here you can see a fractional shortening of 62%. That means heart is contracting well, and here the fractional shortening is 27%, and here you can see the dimension is more. Here the ejection fraction is slightly less. Now coming to fractional area change. Here you measure the initially you measure the volume, then you measure the diameter. Instead of volume and diameter, if you measure the area in end systole and end diastole, it is called the FAC, which is fractional area change. The normal is between 36 to 64%. So for the systolic function, you have ejection fraction, which is the volume. You have the fractional area change, where you measure the area of the left ventricle in systole and diastole. Then you have fractional shortening, where you measure the internal diameter of the ventricle. So, these are the various parameters for assessing the systolic function of the ventricle. As I said earlier, the parasternal long axis view helps in assessing the right ventricle, septum, left ventricle and the posterior wall. If you make a M mode, measurement mode, you can get the dimension of the right ventricle, interventricular septum, left ventricle and the posterior wall. And if you place the measurement mode across the aorta and LA, you get the aortic LA ratio. Normally, the aortic LA ratio is 1. That means the ratio of the aorta and LA is very equal. But sometimes when due to LV dysfunction or something, the LA might enlarge and the ratio might become more than 1. If the ratio is more than 1, your left ventricle is slightly struggling. Here you can see the LA ratio is far bigger than the aortic ratio. Here the LA diameter is 4.5 and the ratio is greater than 1.57. Apart from that, in the 4-chamber view, you can measure the transverse as well as the longitudinal diameter of all the 4 chambers, which becomes very important in case you have a stenotic or a regurgitation lesion of that particular valve. Next comes your hypertrophy. Whether it is concentric hypertrophy, eccentric hypertrophy or a remodel ventricle. How will you know it? For that, you have to measure the dimensions of the interventricular septum, LV cavity and the posterior wall. With the complex formula, you calculate what is called the LV mass, and this LV mass is indexed to body surface area, and the normal LV mass is around 90 to 110 gram per meter square in male and 80 to 100 gram per meter square in females. Okay. There is another terminology called relative wall thickness. This is 2 into posterior wall thickness in diastole divided by left ventricular internal diameter in diastole. If this ratio is greater than 0.42, it is concentric hypertrophy, and if it is less than 0.42, it is eccentric hypertrophy. Concentric hypertrophy is slightly easy to treat, but eccentric hypertrophy, it is very difficult to treat. And here you can see moderate hypertrophy, and this one is severe hypertrophy. Here you can see hardly any ventricular cavity. The ventricular cavity doesn't exist. Severe hypertrophy of the muscle mass is there. These are the cases you should be very careful not to reduce the afterload. If you reduce the afterload with the neuraxial blockade, the entire left ventricular cavity will collapse and the patient will have dangerous hypotension, which is refractory to any treatment. So, always look at the hypertrophy degree in an echo report and accordingly you plan your anesthesia technique. So far, we were looking only about the ejection fraction. Now, let us analyze some echo report. Whenever we have an echo report, we always go with ejection fraction. What will you do with the low ejection fraction? You know that ejection fraction is a volume parameter. Immediately, you should look at the end diastolic and end systolic volume, which is very high. Instead of regional wall motion abnormality, there is global hypokinesia. Here you can see the normal contraction, moderately reduced contraction, and here severely reduced, and here you can see the diameter grossly enlarged. The end diastolic volume is around 262 ml and the end systolic volume is almost 200 ml. The volume is so big. The normal end diastolic volume is around 100 and end systolic volume is around 60 ml. It is almost 4 times the normal. And here you can see the ventricle hardly moving, and this is a short axis view showing global hypokinesia. This is a 4-chamber view. This left ventricular ejection fraction is a major predictor for cardiovascular morbidity and mortality. It is normally between 50 to 60%. Mild LV dysfunction, it is 40 to 45%. Moderate LV dysfunction is between 35 to 40%, and it is severe if it is less than 35%. But you have to understand that you have to interrupt the LV function based on patient clinical status and cardiac condition. When the ejection fraction is in the range of 40 to 50%, you think it is abnormal, but it doesn't have any clinical significance. However, this 40 to 50 will have enough clinical significance if patient has moderate to severe mitral regurgitation. Also, you should understand that LV ejection fraction is a misleading indicator of left ventricular function. Why? Because it is affected by preload and afterload, both of which can change drastically with your volume management in the perioperative period. Now, let us look at the regional wall motion abnormality. Here you can see the apical, anterolateral, inferior, infralateral wall hypokinetic. As you move from apex to base, you have about 17 segments, and this 5 to 6 views are very important in assessing all the 17 segments. Although we have 17 segments, scoring system includes only 16 segments. Let us look at each segment. This is the 4-chamber view. This part is the anterolateral wall, and this is the septal wall. So, you have the baso-inferior septum, mid-inferior septum, apical septum, apical part, apical lateral, anterolateral and basolateral. This is the 4-chamber view. Then as you move into the apical 2-chamber view, you get the apical anterior wall and the basal anterior wall. On this side, it will be the inferior, mid-inferior and basal inferior. This is the apical inferior. Then as you get into the 3-chamber view, you get the apical lateral, mid-infralateral and basal infralateral. This is the parasternal long axis where you can look at the mid-anterior septum, basal anterior septum, mid-infralateral and baso-infralateral. And this is the short axis view where you look at the anterior, lateral, septal and the lateral part. Although you need not look at all the 17 segments, this short axis view in the parasternal is very important, where you can look at the major 4 wall, anterior, inferior, lateral and the septal part. And each of this segment is analyzed for whether they have normal movement, hypokinetic movement, akinetic movement, dyskinetic and aneurysmal movement, and they are allotted a scoring system 1 to 5. Normal is 1, hypokinesia is 2, akinesis is 3, dyskinesis is 4 and aneurysmal is 5. To understand better, see, this is a normal view. Here you can see akinetic in 8 segment and normal movement in other 8 segment. Akinesis is 3 points. So, 8 into 3 will be 24, and there is normal movement in 8 segments, which is 1 point, which is 8. So, 32 out of 16 is 2. If the score is going to be 2 or greater than 2, your ejection fraction is less than 30%. Normally, it is 1 and the ejection fraction is greater than 60%. This is how you analyze the regional wall motion abnormality. Always understand that most of the patient with IHD will have one particular coronary artery involved. So, you have to go with that particular segment instead of looking at whole ejection fraction. Here, you can see a nice 4-chamber view moving normally. Suddenly, you can see the heart is slow and going fast and coming back to normal, then again going slow. This was a clear-cut case of a left anterior descending artery where you can see the apical part not moving at all. Initially it was moving normally, then the new onset apical interval. The chest was closed and if you can see the apical part not moving at all, which was moving normal earlier. If you compare the before and after movement, here you can see the apical part moving normally, here the apical part is not moving at all. This type of new onset regional motion abnormality in the perioperative period always indicates ischemia. Now coming to myocardial performance index, which is called the TI index. This can assess the systolic function. It is also called as the myocardial performance index. Here you adjust the 4-chamber view to get the mitral inflow and LV outflow. You have the mitral inflow and the LV outflow. Here you combine the relaxation and the contraction time and correct it for the ejection time. We have the LV outflow and the mitral inflow, ejection time, isovolumic contraction time and isovolumic relaxation time, and the index is calculated with this formula. The normal myocardial performance index is between 0.39 plus or minus 0.05. When it is greater than 0.59 plus or minus 0.10, it is dilated cardiomyopathy. Higher value indicates more LV disease and poorer prognosis. So far we were looking at the systolic component. Now coming into the diastolic function. When you have a grade 3 diastolic dysfunction, the first thing which we should look is the LA diameter. Here the LAs are enlarged and it is about 43 millimeter. Certain points about diastolic function. Okay, diastolic dysfunction usually precedes the development of left ventricular systolic dysfunction, and whenever LV systolic dysfunction exists, the diastolic dysfunction is already abnormal, and diastolic dysfunction is a strong predictor for all-cause mortality, and up to 1/3 of patients have diastolic dysfunction can have normal systolic function. And also you have to understand that diastolic dysfunction is very difficult to treat than the systolic dysfunction, and it can cause refractory hypotension in the perioperative period which won't respond to any treatment. The common causes for diastolic dysfunction includes old age, hypertension and myocardial ischemia. And this diastolic dysfunction is measured by placing a pulse wave probe across the mitral valve, and we measure what is called the EA ratio. E is for rapid filling and A is for atrial contraction. And another one is you measure the pulmonary vein Doppler. You place the pulse wave Doppler across the left upper lobe pulmonary vein and you can measure the systolic wave, diastolic wave and atrial reversal wave. Here you can see the systolic wave, diastolic wave and the atrial reversal wave. Then apart from that, here you measure the E prime, A prime and the S prime waves. And the normal E prime value is less than 8 cm per second. These are the various waveforms which you obtain as the diastolic dysfunction progresses. You can see the EA ratio and the pulmonary vein morphology with increasing diastolic dysfunction. But what is more important is, as the diastolic dysfunction progresses, your compliance comes down, your left atrial pressure increases and the relaxation becomes increasingly impaired. Now coming to another important chamber of the heart which you often neglect, which is right ventricle. You have to understand that all your anesthetic maneuvers affects right ventricle more than left ventricle, and the treatment options for left ventricle are many, but right ventricle it is very minimal. Here you have the right ventricular dysfunction. Whenever you have a right ventricular dysfunction, you have to look at the pulmonary artery pressure and whether any tricuspid regurgitation is there. Quite an easy way to assess the right ventricle dysfunction is look at the volume dimension when compared to the left ventricle. Here, the right ventricle is smaller than the left ventricle. Your right ventricle is normal. When the size is equal to left ventricle, it is moderate. When the size is more than the left ventricle and when it forms the apex, it is severe RV dysfunction. Here you can see the MRI where the right ventricle is smaller than the left ventricle, which means right ventricle is normal. Here you can see the right ventricle size is almost more than the left ventricle. Then you can see severe dysfunction with severe TR. Another important thing is you can see the septal movement. The septum moving towards the left ventricle is abnormal. The septum normally move towards the right ventricle. When the septum move towards the left ventricle, it is abnormal. The most common way to assess right ventricular dysfunction is what is called TAPSE, which is tricuspid annular plane systolic exertion. It is simple, reproducible and represented longitudinal function of the right ventricle. In the apical 4-chamber view, you place the cursor across the right tricuspid annulus and you take average over 3 beat. Normally, the TAPSE is greater than 16 millimeter. In RV dysfunction, it is going to be less than 16 millimeter. Another way to assess the RV dysfunction is measure the area in systole and diastole, which is called the functional area change. Here, the fractional area change is 60%. As it comes down, your RV dysfunction exists. So, what are the signs of RV dysfunction in the echocardiogram? You have RV hypertrophy, paradoxical septal motion, RA enlargement, pronounced right to left bowing of the interatrial septum as your RA pressure goes up, tricuspid regurgitation, reduced systolic wall thickening and ventricular dilatation. For measuring the PA pressure, you should have a slight jet of TR. Here, the TR velocity is around 2.26 meter per second, and to convert this velocity into gradient, you have to apply the Bernoulli's theorem, which is 4 times the velocity square. So, 4 times into 2.26 square equals to a gradient of around 27.7. When you add the CVP, which is measured by a monitor, that is 10, you get a PA pressure or a RV systolic pressure of around 37 millimeter of mercury. And by measuring this pressure, you can know what is your grade of pulmonary artery hypertension. If the mean is greater than 30, it is mild. If it is greater than 40, it is moderate. And severe PAH is when the mean pulmonary artery pressure is greater than 50 millimeter of mercury, or if it is greater than 60 millimeter of mercury, it is called systemic or suprasystemic. Why you are worried about this PA pressure? You have to understand that right ventricle never tolerates pressure overload. As your pressure increases, the right ventricle enlarges and it pushes the septum towards the left ventricle. So, with increasing PA pressure, your right ventricle function is compromised. By pushing the septum towards the left ventricle, your left ventricle function is also compromised. So, you have to be very careful not to induce increased PA pressure during your anesthesia period. Now, we looked at the left ventricle systolic, diastolic, regional wall motion, ejection fraction. Then we looked at the right ventricle. Now, we have to look at the volume parameter. Here, you have a dilated inferior vena cava, which is not collapsing, which means your volume is loaded. You look at the IVC diameter and the collapsibility of the IVC. The normal IVC diameter is around 1 to 2 centimeter. If your IVC diameter is less than 2.1 and the collapsibility is greater than 50%, your CVP is low. It is around 3. The diameter is less than 2.1, but the collapsibility is less than 50%. Your CVP is around 8. The diameter is more, but still some amount of collapsibility is there. Again, the CVP is 8. The diameter is high and there is less collapsibility. Your CVP is really high. And this is the short axis view which was taken during the perioperative period while you fill the ventricle. This was while coming off bypass. As you fill with volume, you can see the LV cavity getting enlarged. Here suddenly the area has increased tremendously. See here, you can see a small ventricle, and here you can see an enlarged ventricle. So always you have to be very careful when you suddenly volume load the patient. The ventricle will dilate immediately, and if the ventricle function is not adequate, it cannot accommodate this sudden surge of volume. So always you should assess the volume stated with the IVC diameter and fill the patient accordingly, or you have to look for a dynamic indices of volume responsiveness, which is stroke volume variation or pulse pressure variation. Now coming to the final part of the echo report, where you look at the 4 major valves. When you have stenosis, you have to look at the valve area, what is the gradient across the valve, how much hypertrophy is caused due to stenosis, and what is the pressure in the proximal chamber to the stenosis. In case of regurgitation, you should look at the chamber enlargement, how much volume is regurgitated. You should look at the regurgitation velocity, and always understand that whenever there is regurgitation, there is overestimation of ejection fraction. Coming to mitral stenosis, here you look at the mitral valve gradient and the area and classify accordingly, and LA enlargement will be there, and this will reflect back on right ventricle. So you have to look at the LA enlargement as well as right ventricular assessment, and as LA enlarges, there is a chance of atrial fibrillation, and as the atrium does not contract, there will be stagnation of the blood, which might lead to thrombus formation. Here you can see the stasis of the blood and the mitral, which has severely calcified and not opening. Here you can see a large thrombus which is attached to the roof of the LA. Here you can see a thrombus which is moving across the mitral valve. This type of embolus, you have to be very careful. If you give a cardioversion, this might embolize. And coming to regurgitation, here you have severe left atrium and left ventricular dilatation. You should look for papillary muscle rupture or caudal rupture. The velocity of the regurgitant jet is very important to assess the pressure proximal and distal, and don't forget that it overestimates ejection fraction. Here you can see a eccentric MR, LV diameter is enlarged, and coming to aortic stenosis, you might have thickened, calcified, immobile aortic valve cusps. There is going to be severe left ventricular hypertrophy, and you measure the gradient across the valve provided the left ventricle function is reasonable. If left ventricle is not moving adequately, you might underestimate the gradient. Here you can see calcium across the aortic valve and severe concentric hypertrophy of the left ventricle, calcium across the aortic valve. And coming to aortic regurgitation, you have to measure the degree of regurgitation, determine the velocity, again overestimation of ejection fraction. Here you can see a nice aortic regurgitation, and you can see the dissection in the aorta which is causing aortic regurgitation. Now coming to the congenital heart disease aspect, you have to look at the interatrial and the intraventricular septum. Here the patient has a large ASD 1.7 centimeter with the left to right shunt. Here there is a large ASD which measures about 1.2 centimeter. How can you calculate the degree of shunt? All you need to know is the diameter of the ASD. The diameter is around 1.2. For calculating the area, pi r square is applied. Okay. If the diameter is 1.2, the radius is 0.6 and pi value is 3.14. So you can calculate the orifice area. And to calculate the velocity integral, you place the cursor across the ASD, you get a velocity integral of around 80 centimeter and you need the heart rate. So, shunt is equal to orifice area into the velocity integral into the heart rate. If you substitute the value, you get a left to right shunt of 9 liters per minute. This is how you calculate a shunt across the ASD. Now, coming to the last part where you look for other structures. Here, patient has pericardial effusion. This is the pericardial effusion. You should understand that 1 centimeter of water is equal to 100 ml. This part is around 1 centimeter. That means 100 ml of fluid is being collected. To summarize, first thing is you look whether the patient report reflects the patient current status. Clinical examination is very important. And why you ask for echocardiogram? The questions should be answered. Whether the patient rate and rhythm was normal when you are doing the echocardiogram. Always look for chamber size. Evidence of dilatation by transverse diameter. In case of left atrium, always go for volume rather than diameter. In case of hypertrophy, just look at the regional wall thickness to assess whether it is concentric or eccentric hypertrophy. And coming to systolic function, it is graded 1 to 4. 1 is normal, 4 is severely abnormal. Grade 2 can be normal in atrial fibrillation and grade 1 can be abnormal in mitral regurgitation, which overestimates your ejection fraction. You have to understand that left ventricular ejection fraction is a poor indicator of left ventricular function because it changes with your volume management. Global abnormalities suggest cardiomyopathy. Regional abnormalities suggest ischemia. Coming to diastolic function, it is graded normal or class 1 to 4 diastolic dysfunction. The term mild diastolic dysfunction is misleading. You don't know whether it is normal or abnormal. And with regard to right ventricular function, you have to, in addition, you have to assess the tricuspid regurgitation, pulmonary artery pressure and right ventricular function. You have to look at the all 4 valves, interatrial septum, interventricular septum, and don't forget to screen for pleurum, pericardia, great vessels and in addition any mass or thrombus. So, by knowing this echo, how anesthesiologist perspective changes. I have underlined something in red. You can see various percentage which are almost above 50% in most of the studies. With the knowledge of echocardiogram, your anesthetic and hemodynamic management changed in more than 50% of the cases. If anesthetist knowledge of echo is there, the hemodynamic and your anesthetic management changes. And it was helpful in all cases, and in 1/3 of the patient where the surgery was cancelled, the anesthesiologist doesn't know echo, was given fitness and managed very successfully. When you hear like this, you may forget. When you see, you may remember. But unless you do echo, you will never understand. Thank you.